Okay, hello again everyone. From Paris, we're at the 2017 IAS meeting on HIV science. This is the last day and I'm here today with Laura Waters from Mortimer Market in London. And she'll give us a little, she spoke at a meeting earlier in the week about UK funding and UK possibilities of changing the administration and how to use drugs, and maybe we can talk a little bit about that and other things that have happened here at the conference this week. So tell us a little bit about the BIVA presentation and what your goal was and how maybe to make the funding a little bit better.
Yeah, so it was our British HIV Association symposium. So for a start, this was the first time we'd actually applied to run our own independent symposium at the conference. It was a 7 a.m. slot, but all considered, we got a reasonable turnout. So like every other country in the world, we have increasingly limited resources, but we have an increasing prevalent population of people with HIV. We have a fairly steady, until last year, number of new diagnoses each year. We did see a drop last year for the first time in men who have sex with men. But we've still got thousands of new infections every year. We have people living normal life expectancy when they're well treated, but we have clinics that are getting no more funding, no more staff to manage increasing numbers of people. So one of the things that we've pursued quite aggressively is the use of generics. So generic drugs are very much promoted in our National Health Service anyway. About 70% of all prescribing across all disease areas is using generic medication. And we've developed a very active program around switching people to generics when there are.
But that's still respecting intellectual property and everything, of course.
Oh, absolutely, yes? Absolutely. We do not use generics outside of the existing rules and regulations, and as a resource-rich Western European country, we cannot use generics until the patent has expired. So, did I ruin that? So, for example, we routinely switch people on branded Kyvexa to generic abacavir and lamivudine, which saves an awful lot of money. We switch people from a tripler single tablet regimen where they are happy to take 2 pills to Truvada and generic efavirenz, and as an example, that saves £700 a year. We have a very open dialogue with patients. We have realistic goals. So nationally, we're expected to switch 60% of people from a tripler to Truvada and generic efavirenz, which leaves 40% where people want to stay on single tablet regimen. We can support that. So we've been pretty successful, and the estimated savings after 2 years are going to be £32 million, which clearly in a stretched National Health Service is a lot of money. One of the key things that we've done at every level, though, is engage patients. So we have peer representatives, patient community representatives at every level that we work at. So on our national gold standard guidelines, but on our regional guidelines, on our HIV clinical reference group, who's a group of different stakeholders who advise NHS England about what to do, patient representation, patient information, and actually the community have been fantastic at encouraging and supporting people about the safety of generics.
I noticed on one of your slides you also talked about, even in the case of having to take more pills, we should go to generics. And the patients in your advisory groups are okay with that?
Absolutely. Again, I think by using the cheaper options for most, it preserves the financial luxury of single tablet regimens for those that really need single tablets. And for some people, that is essential. That's the difference between a detectable and undetectable viral load, but we still honour that and support that by ensuring that those who are able and willing to take more pills do so to create the funding for more expensive branded regimens.
And if PrEP were prescribed more nationally and more globally completely, that would probably also help,
No,
correct?
Absolutely. I mean, certainly the downturn in new diagnoses we've seen in MSM at home has been driven, we think, by increased testing frequency, by a reduction in the proportion with undiagnosed HIV, and by treating people earlier. So 96% of all diagnosed people at home are on treatment. Now, that increase in testing frequency at some of the core London services is at least in part, we think, driven by people coming for PrEP monitoring. So although we don't routinely provide PrEP, we signpost people towards generic websites where they buy their own generic medication, which is legal. It's completely legal, although we can't use generic Truvada. People who want to buy generic Truvada can do so legally. So we support people on generic Truvada in terms of offering advice about dosing, safety monitoring, etc., etc. And we think that is what's driving people to come to clinics more often, test more often, and altogether that's combining. We will roll out PrEP. We've got a large trial planned imminently. NHS England have put £10 million into running the PrEP Impact trial, which is essentially rolling out generic Truvada within a trial to, we hope, 10,000 at-risk people.
Great. And one final question about finances. Generally, do you think dual therapy, this idea of going to dual therapy, also might be a little bit of a cost savings?
No, I mean, absolutely. So, I mean, certainly if you look at, there have been a number of cost effectiveness analyses looking at dolutegravir and lamivudine, for example, and absolutely, I think particularly when it's a kind of newer drug like dolutegravir combined with a kind of stalwart, been around forever and costs virtually nothing drug like lamivudine, the scope is really quite exciting. I think for some other combinations, certainly in resource-rich countries, so dolutegravir or pivarine, for example, may not be a particularly cheap option for us because you're looking at 2/3 agents put together.
Yeah.
Whereas bearing in mind that our NRTI backbones are increasingly available as generics, then the
Right.
balance may differ. But certainly, I think dual therapy, and some of the data at this meeting, I think has been really supportive around dual therapy. But the key thing with dual therapy, though, is to wait for the proper trials. We've got some pilot studies showing data for some of the dual combinations, but I think studying them in proper randomised controlled trials with adequate numbers of people for adequate durations of follow-up is essential.
I didn't wait. I hope that's okay. I just did dual because I thought that was most appropriate for me.
I think for most people, dual is absolutely fine, but we've learned from some examples. So one
I
example,
didn't start on dual.
yeah, and I think that's the thing. It's a simplification option more than an initial option. There's still a lot to learn, but I mean, again, it's been a real focus of this conference, and I think 2 drug regimens really are looking to be the future.
Right. Which is good for everyone, for tolerance as well, for
Absolutely.
the person taking them as well.
Absolutely.
I think. So, what other things have you come across this week here? Now that it's the final day of the meeting, that have struck you as being particularly interesting? I mean, for example, I know there's been lots. For me, I've been struck by the amount of work being done on PrEP in the myriad of ways that's happening.
Yeah, no, I think there's been some very interesting discussions and presentations around PrEP and how to support it. I think there's some very interesting work, because I think one of the big objections to PrEP is like, well, people won't use condoms, they won't use other risk reduction methods. And actually there was some interesting work presented from some qualitative interviews within the PROUD study, really showing that men accessing PrEP are incorporating PrEP into their existing repertoire of risk reduction strategies. So it's an additive thing rather than a replacement thing. We do know from other studies that condom use goes down, but it doesn't mean people are just going, sod everything else, I'm only going to rely on PrEP. And it was interesting. And also some of the sort of psychological benefits of PrEP, I did think was really interesting. And the fact that actually PrEP made people feel more comfortable, more relaxed, more able to enjoy a normal, healthy sex life.
Sure.
Which is important.
Right, of course. Were there, I don't know if you saw any of the new drug sessions or anything?
Yeah. Yes.
And anything particularly striking or interesting?
Yeah, I mean, I think it's difficult these days, because when you've got efficacy rates of, more than 90% at week 48, you really are splitting hairs sometimes, which is fantastic, because it just shows us how much antiretroviral therapy has evolved, that to be in the luxury that you're debating tiny differences in lipid ratios is fantastic. So I think certainly the bictegravir data is looking very promising. What else do we see? We saw the doravirine data. I think doravirine, and I think non-nukes as a class aren't dead. I think globally there's this real move. It's the integrase era. IAS now recommends only integrases first line in their guidelines. But I think non-nukes are a very reliable class, a class we've got a lot of experience with, and I do think doravirine is of interest. The resistant rates, although not high, were slightly higher than I had hoped based on some earlier data comparing doravirine to a PI, but still it looked well tolerated, and I think that's, we need choice. Integrases are fantastic, but they're not going to be right for 100% of people.
Of course. And finally, I just think that for me also it's been sort of jarring, the difference between the luxuries we have in Europe in the north, and the fact that still it's about 40% of people who have even the option of any treatment in the south. And you know, UNAIDS and the WHO and everyone is trying to make that better, but it's a long slog.
No, it's a long slog, and I think it is. You're right. It's sobering and quite saddening just how far we have to go in terms of getting people on any antiretrovirals. But that's where I think some of the novel drugs have such great potential, and I think a lot of the discussion and already rolling out of dolutegravir first line in resource limited settings, it's well tolerated, low resistance, it's safe, and if you've got those safe drugs priced at a level that they're suitable for first line treatment globally, then you can get them out to more people.
And in the case of dolutegravir, with everyone in developing countries who probably has resistance to efavirenz after so many years on efavirenz, dolutegravir is a good second line.
No, it absolutely is.
Line.
And we saw the data yesterday comparing dolutegravir with lopinavir, ritonavir after first line treatment failure, and it was superior. Quite how that data would look if dolutegravir was a routine first-line option would be interesting. Of course, we're not in a position to be able to study that yet, and we know that dolutegravir generally doesn't lead to resistance. But will dolutegravir second-line perform as well after dolutegravir failure as it does after non-nuke failure? I think that needs to be addressed in a trial.
Laura, thanks a million for
you.
being here and helping us out and giving us some fresh information from IAS. Thank you.